So here we have test question. Pause the video, take a few minutes, read this test, guess which answer is correct, and after, let's discuss this test step by step. So, it's 60-year-old man. His major complaints is fatigue and shortness of breath. Also, on physical examination he is pale. And as we see already from his blood analysis, he has anemia. In his anamnesis, there are two concerning features. First of all, it's rheumatoid arthritis, which is a chronic autoimmune disorder that can cause chronic inflammation, and thereby it can be the cause of anemia of chronic disease. And the second feature is methotrexate. We know that methotrexate is a folic acid antagonist that can cause folic deficiency anemia. His hemoglobin is 92, which is low. Decrease in hemoglobin we call anemia. Anemia explains his complaints on fatigue and shortness of breath, and we know that anemia classified based on severity and the size of red blood cells. To determine severity of anemia, we have to know two numbers. It's 110 and 80. Also in this case, it's a man, and the lower limit of normal for hemoglobin in man is 130. So, from 130 to 110 is mild anemia, from 110 to 80 moderate, and lower than 80 is severe. In this case, hemoglobin is 92, so it's moderate anemia. The type of anemia we determine by the size of red blood cells. And to determine the size of red blood cells, we look at MCV. In case of MCV, we have to know two numbers. It's 100 and 80. Everything above 100 it's macrocytic, between 100 and 80 normocytic, and lower than 80 is microcytic. In this case, MCV is 88, which is normocytic anemia. So, in this case, patient has moderate normocytic anemia. Once we see normocytic anemia, usually, the first possibility that comes to mind is hemolytic anemia. His red blood cells are low, so maybe something destroying them. But hemolytic anemia in this case is highly unlikely. First of all, reticulocytes are not elevated, and patient do not have jaundice. So here we have red blood cell, and within the red blood cell is hemoglobin. If hemolysis occurs, red blood cells release hemoglobin into the blood. Hemoglobin degrades into protoporphyrin, and protoporphyrin undergo conversion to bilirubin, and increase in bilirubin causes jaundice. Also, in response to hemolysis, bone marrow increases the production of new red blood cells, and increase in red blood cells production we determine by increase in reticulocytes, which are red blood cell precursors. In this case, jaundice is absent and reticulocytes are low. But in his analysis, we also see increase in ferritin and decrease in transferrin saturation. What does this mean? Recall that we have ferritin that serves as iron depot. We have transferrin that delivers blood to ferritin and serum iron, and we have serum iron, which we use to make hemoglobin. Usually, we take serum iron from ferritin, which is logical because ferritin is the depot of iron. Also, we know that the level of transferrin depends on level of ferritin. Basically, the higher the ferritin level, the lower is the level of transferrin. In anemia of chronic disease, chronic inflammation, in this case inflammation caused by rheumatoid arthritis, cause increase in production of pro-inflammatory cytokines, which in turn stimulates the production of hepcidin, and hepcidin blocks the release of iron from ferritin. So this will cause accumulation of iron in the depot, thereby ferritin level will increase, and at the same time it will cause decrease in serum iron, which will cause microcytic anemia. Also, because ferritin level will increase, the level of transferrin in the blood will decrease. As we see in this case, patient has transferrin saturation 18%. What does this mean? In normal condition, we have 3 transferrin molecules per 1 iron molecule, which gives transferrin saturation approximately 33%. In this case, the release of iron from the depot is blocked, so the level of serum iron will significantly decrease. But the production of transferrin is just inhibited. Organism still produces transferrin. So in this case, there will be, for example, 9 transferrin molecules per 1 iron molecule, which gives transferrin saturation of 11%, which is low. So in anemia of chronic disease, transferrin saturation is low, even though transferrin level in the blood is decreased. The only question that remains is that why in this case anemia is normocytic, why it's not microcytic as it should be in anemia of chronic disease. Recall that we have 4 microcytic anemia. It's iron deficiency anemia, anemia of chronic disease, sideroblastic anemia, and thalassemia. They all lead to formation of small red blood cells. But in this case, patient intakes methotrexate, and we know that methotrexate can create folate deficiency, and folate deficiency causes formation of macrocytic red blood cells. Recall that we have only 2 macrocytic anemia. It's B12 deficiency anemia and folate deficiency. So in this case, most likely, microcytic anemia combined with macrocytic anemia caused formation of normocytes. But the correct answer here will be anemia of chronic disease, primarily because patient has elevated ferritin level.